So in 2019, we published a trial where we looked at Nabilone. Nabilone is a cannabinoid 1 and cannabinoid 2 receptor partial agonist. So it's actually synthetic THC. That's why it's a cannabinoid. And we picked that particular medication because it's already on the market. It's a repurposing type of trial. And it has good bioavailability, and you can give it twice daily. So that's Nabilone. What we did for our first trial was do a crossover trial. So that means that each participant in the trial gets either medication or placebo in a randomized order. And we recruited 39 patients for that trial, and 38 of them had, in the modified intent to treat analysis, 38 of them had at least one measurement post-randomization. So that was the design of the trial. We gave Nabilone 1 to 2 milligrams per day. We tapered up. If they couldn't tolerate the 2 milligrams per day, they could be back down to 1 milligram per day. Each treatment phase was 6 weeks with a 1-week placebo washout in between. In this particular trial, our major outcome variable was NPI agitation. And we found that there was a significant decrease in NPI agitation in the Nabilone phase compared to the placebo phase. We also looked at clinical global impression of change. As you know, for clinical global impression of change, that's meant to say whether statistically significant findings are actually clinically significant. In this pilot trial, it was not significant. But we had a p-value of 0.09. But what we did find in CGI-C was that 47% of people on Nabilone had response as measured by the clinician compared to 23% on placebo. And that was minimal to marked improvement. The other things that improved are overall neuropsychiatric symptoms. So these are secondary outcomes. You want to make sure when you're giving a medication that you're not, for example, with this particular group of medications, making the psychotic symptoms worse. So overall neuropsychiatric symptoms also improved, and we had a second measure of agitation that improved as well. So as I mentioned, for Nabilone, we had a 47% response, and for placebo, we had a 23% chance of response. So we know that in general, variability in treatment response can be related to clinical factors. So what we did in this post hoc analysis is we had 19 potential predictors that were chosen a priori. We looked at whether people had a greater response on the placebo phase or the Nabilone phase for these 19 predictors. And the predictors were things like demographics, concomitant medications, the presence of other neuropsychiatric symptoms, and severity of cognitive impairment, as well as pain, because we know that cannabinoids can be used to treat pain. So we plotted all of those particular predictors, and we found that there were 6 that were important predictors. If the patient had less cognitive impairment at baseline, greater pain, whether they had NPI irritability, so having it was a predictor of response to Nabilone, whether they had appetite changes. We know that undernutrition tends to progress with dementia, and that malnourishment is associated with agitation. And if they had NPI depression. The 6th point that we found was that they were not taking cholinesterase inhibitors. We do know that cholinesterase inhibitors, as I mentioned, don't particularly improve agitation in randomized placebo-controlled trials, even though they help possibly with emergence. But cannabinoids also inhibit cholinesterase inhibitors. So cholinesterase, so there may be some interaction that's going on there. So those were the 6 predictors. How well did these predictors work? Well, if you add up a patient's score on these predictors, the patients who were in the top quartile had about an 89% chance of responding to Nabilone versus placebo, whereas if you're in the bottom quartile, you have about a 33% chance of response, and that was statistically significant. However, this was in run trial. So the next step for this would be validation, and we are running a larger trial that we can validate these predictors in.